Good evening once again. And instead of one, I'm going to present you briefly two interesting cases of transcatheter pulmonary valve implantation. Unfortunately, I don't have a live video, but I will try to give you a precise image of the procedure using angiographic images. So the first case, it's a male patient, 30 years old, with phallotetralogy and DiGeorge syndrome, which had the complete surgical repair of TOF at the age of 16 months. And in 2009, she had a surgical pulmonary valve replacement with a 27 millimeters Magna Edwards bioprosthesis. He also has a history of psychiatric disorders. Now the patient has progressive decline in his functional status from NIHA 2 to 3. And we found from our assessment a mixed pulmonary valve disease with moderate stenosis and regurgitation and severe RV dilatation and RV systolic function, as you can see from the measurements from the CMR. Now the echo, as you can see, we have a really importantly dilated right ventricle with impaired systolic function and a moderate stenosis and regurgitation. The patient also underwent a CT and CTCA, which showed that the coronary anatomy was typical of TOF, and both coronary arteries were located well away from the existing pulmonary bioprosthesis, so we know we have a low risk of coronary compression. And now, in order to choose the valve that we are going to use, we know that the patient has a C Magna and 25 millimeters. So this patient from the upper, we see that it has an internal dimension of 25, which can be bigger because the valve is fracturable. So you can see here that based on this, we can use a 29 millimeter balloon expanding valve. So we move on to the procedure. The patient was intubated. The access sites were both the femoral veins, the left and the right. And we also used the right femoral artery in order to advance Judkins left catheter and in order to see if we have a patent LCA throughout the procedure. So we started with right heart catheterization and right ventriculography. You can see the extremely large RV of the patient with impaired systolic function. And you see that the patient has a pressure of right ventricular pressure of 68 with an aortic pressure of 76, which means that the right pressure is almost equal to the systematic pressure. And we have a pressure gradient between RV and PA of 13 millimeters. So we advanced a Landerquist wire to the right pulmonary artery from the right femoral vein and an Applet superstive wire to the left pulmonary artery through the left ventricular vein. And we also advanced, as I said, Judkins left catheter to the LCA. Now, through these wires, we advanced and dilated two Atlas balloons, 16 and 18 millimeters, in order to dilate and crack the valve. You see, we have full expansion of the balloons, but we still are not sure that we have make the fracture of the valve. So we make again a dilatation with 18 and 20 balloons this time. And at some time, we feel the loss of pressure. So we know we have make the crack. And in fact, you can see this because here you can see the cracked flail leaflet of the valve. So After that, we advanced a 26 dry seal sheath distal to the prosthetic valve, and through this, we advanced and implanted a 29 MyVal valve. And you see that we at the full expansion, we have complete pinning of the rupture bioprosthetic leaflet. So then, after the placement of the valve, we checked the flow of the LCA, and you see we have no impaired flow. And we did the contrast injection in the low left pulmonary artery to exclude that we have made the vessel perforation with the stiff wire. And at the end, we did the final angio within the PA, and you see the excellent valve function without regurgitation. Now you see the difference in the pressures before and after the procedure. Previously, we had almost equal pressures, right and systematic pressure, and now the right ventricle pressure is less than the 1/3 of the systematic, and we have a very good result with a gradient between RV and PA of 9 millimeters. So the post-procedural course of the patient was uneventful, and after 5 days, he was discharged. And you see the pre-discharge echo. We have less D-shape, and the pulmonary valve looks okay, and we have a max velocity through the valve of 1.5 meters per second. So we now move on to the next case, which was done via the transjugular access, and I'll explain why it happened.
Hold on a second, just to clarify. So in this first case, what was the size and the type of the valve? I missed that, of the original valve.
27 Magna Ease. So the external ID of the valve was 27.
So the approach to use two balloons, we don't use it in, for instance, in TAVI when we wanted to crack a valve. So why do you do that, or you're not?
We do that because we know that the maximal high pressure balloon that we are having is 26. We do not have more than that. The true balloons that they are coming up to 30 that you are using by TAVI, nominal pressure is around 6 atmospheres. Of course, you can overexpand with an insufflator, and you can go up to 12 atmospheres. But we know from different studies that the way to break the valve, it is that you need at least 3 millimeter larger diameter of the balloons than the nominal valve that you want to break, and you need at least a high pressure up to 16 or 18 atmospheres. That's why. So this double balloon also technique offers us an open outflow tract in the right ventricle, because at the end, when you are expanding the balloons, you do not have a circular shape of the two balloons, but you are having an oval shape, which means that you are allowing a little bit of forward flow, so you do not reduce totally the cardiac output. In that way, you are keeping the patient more stable. And additional to that, we know that the enforcement that you are putting on it will be in one direction, whichever direction the balloon sits, of course, but this is the way to do it.
Okay, that's interesting. We have Dr. Mariano and Dr. Sparias. Would you crack an aortic valve like that, in that fashion? In aortic. So
yeah,
to use a two balloon technique.
Yeah, a two balloon, certainly larger than the inner diameter of the valve.
Yes, but they use two balloons instead of
two balloons instead of one.
Yeah.
No, never had to use that.
Dr.
I used two balloon.
We were, maybe
never two balloon. Maybe it's interesting, very interesting.
Yes.
Till now, no, never.
We don't do that, but that's
Maybe
why we have you here. We learn new things. So maybe the right, the right heart space. Maybe it's more accommodating, more forgiving. I don't know if we could do that. in aortic area.
I fully understand that because in the aortic position, unfortunately, you do not have you have a calcification around the coronary arteries, and that's why you don't know how the balloons will sit and which direction they will break.
So the next case is a 26 years old female patient who had a history of repaired tetralogy of Fallot at the age of 26 years with residual pulmonary stenosis and regurgitation. He had also made the implantation of 39 CP stent at the origin of the left pulmonary artery in 2007 using a 16 millimeter BAB balloon. And he also has a history of flutter ablation in 2021 and an ICT implantation in 2023 after positive VT stim. And now the patient has progressive decline in exercise tolerance over the past year, and he has exertional dyspnea, 2 to 3 class NIHA, and lower extremity edema, and he has multiple hospitalization for cardiorenal syndrome and decompensated right heart failure with peripheral edemas. So you see from the echocardiogram in our department that the patient has severely dilated right atrium and ventricle with severe tricuspid regurgitation and impaired right ventricular function. And he has a mixed, he has stenosis, but his main problem is the regurgitation, which you see it's moderate to severe. Now the patient underwent CTCA, mainly because he was 63 years old and we wanted to exclude the coronary artery disease, but we also measured the distance between the coronary arteries and the LVOT, and we had the first measurements of their VOT dimensions. So we move on to the procedure. The patient was intubated. The exercise was the right femoral vein, and we used again the left femoral artery in order to have to see the LCA flow throughout the procedure. Now you see from the ventriculography and the angiography before the procedure that we have again an impaired systolic function of the RV, and we have moderate to severe pulmonary regurgitation, and you see the pressure in the RV, it's elevated, it's 56, and we have a gradient of about 10 millimeters between RV and PA, meaning that the stenosis is mild. Now, we advanced an applet super stiff wire, and in order to be sure that we're not going to impair the flow in the LCA, we did a balloon occlusion test using semi-compliant balloon 24 to 45, and we saw, as you can see, that the coronary flow was not compromised. So we extended the wire to a Landerquist, and we attempted to advance 16 French sheath into the pulmonary artery, but you see that we couldn't do this despite push and pull maneuvers and despite using a balloon-assisted tracking technique with an Armada 10 to 60 millimeters balloon. After a lot of effort, we also tried to use another seat. So we tried to advance 24 French dry seal sheath, and we repeat the advancement attempt, but again, it was successful. So we decided to change access and use the jugular vein. So you see we have again inserted this 24 French sheath via the jugular vein, and we try again to pass the RVOT, which is calcified, as you can see, and we can't. So again, we used a balloon to help us cross the RVOT, but again, we're stuck in the calcified RVOT. So we exchanged the balloon that we used to a bigger Atlas 14 to 40 millimeters balloon. And you see that with this balloon, we managed to cross the RVOT. After that, we advanced 10Z covered CP 50 millimeter stent mounted at 24 millimeter BIB balloon. And after confirmation of appropriate placement of this stent in the RVOT, we did stent stabilization with this 24 BIB balloon. And after that, we did the further anchoring of the stent with the use of an Atlas 26 millimeters balloon. And you see that after the full expansion, we have some recoil. And when we measure the final stent diameter after the expansion, this is 21 millimeters. After the stent expansion, we did an LCA flow assessment, and we see that it is okay. And again, with the same technique, with the use of the Atlas balloon, we repeat the distal advancement of the dry seal sheath. And through it, we advance the 26 MyValve valve that we selected to implant to the patient, and we do the valve deployment. As you can see here, it takes a few seconds. But at the end, the valve is full expanded. And we did, after the valve expansion, we again did the final LCA flow assessment. We did the hand injection confirming adequate valve sealing and elimination of the regurgitation. And you can see from the RV pressure that now is 41 instead of 50 that we had before. And we have an excellent pressure gradient of only 3 millimeters of mercury. Again, the post-procedural course of the patient was uneventful, and you see the echo, pre-discharge echo, and the patient has no regurgitation. The pulmonary valve has no regurgitation, and it has a maximal velocity of 1.7 meters per second. Thank you.
Well done, Poppy. Excellent presentation. So, any specific information, or why did you choose MyValve instead of Edwards, for instance? In the old times, you would use a Melody as well, or not?
Yes, Melody, I think it is the forgotten valve anymore, because we know that the material that it is coming from is having more a risk of endocarditis. This is proven. Nowadays, also the Contegra conduits that the surgeons were using in the past, they had exactly the same problem, so we have moved away from that. The second thing is that it is limited diameter expansion up to 22 nominal, 24 in a maximum diameter, so you cannot go for bigger valves. And as we know, if a surgeon would choose to place a valve, it would be at least 26 in the nominal diameter, so we try to do as much as that and to expand the valve further than that in order to have valvations in the future. Why MyValve? Because MyValve is more or less the same material as it is the Edwards. Is giving us more options because of the intermediate sizes of 21.5, of 27.5 and 30.5, so we have a more precise diameter expectancy, and we know that the valve leaflets, they will not be compromised either from under expansion or over expansion.
And how do you make the sizing? How do you make the size? Do you use
We always go by the height and the PSA and the body surface area and the height in order to have the, according to the nominal body weight and height of the patient, we are choosing that what it should be the size of the pulmonary artery, and according to that, then we try to come closer to that. We know from studies that we have done, and we have already published that if you have a Z-score that it is less than -0.1, then you do not have narrowing, and you have a better extension of the valve life.
Excellent, good. Any comments from the audience? Also, we can have comments from the chat. We have 40 colleagues remote as remote audience, so still we can accommodate these questions. So,
what is the, have you any idea, what is the expected number of patients in Greece with pulmonic valves?
This is very difficult to say so because there is no formal registry of the patients with congenital heart disease or with pulmonary valve needs. We expect, according to the numbers of the population that we are having, to be around 20 to 25 patients per year.
okay, so thank you very much. Thank you for your contribution. Thank you, Poppy. So we have